Hi, and welcome to The Doctor Is In. I'm Frank Speidel, a retired emergency physician and recovering hospital administrator. For what I will discuss and offer today, I invite your robust doubt and skepticism. The great physicist, Dr. Jacob Bronowski, reminded us, it is important that students bring a certain ragamuffin, barefoot irreverence to their studies. They are not here to worship what is known, but to question it. Jacob also wrote, there is no absolute knowledge, and those who claim it, whether they are scientists or dogmatists, open the door to tragedy. So much for subtle science. Now, I am neither an epidemiologist, public health official, nor infectious disease specialist. I invite you always to defer for healthcare guidance to your primary physician, your local and state health departments, and the CDC. As I wrote the introduction to today's show, we had lost 184,000 Americans to COVID-19. In a prior show, I commented on a serology-based infection fatality risk report published in the July 14th, 2020 Lancet Infectious Disease Journal. This study suggests that COVID-19 to be predominantly a lethal threat to those over 64, with a diminishingly small threat to those under 49. I note that the study out of Geneva, Switzerland is echoed in the CDC's provisional death count for COVID-19 as of August 26, 2020. The deaths reported here are for the period from February 1st to August 22nd and are consistent with the Lancet study. If you note, you'll see that 18 to 24 has hundreds, specifically has 330, whereas when we get up to 85 years of age, in that time period, beginning in February, CDC is reporting 50,000. It's almost a reasonable, it's a mappable progression as you increase in age. I would also like to comment that the Geneva Lancet study reports an infected fatality rate based on serologic studies, which suggests who was infected, not just who we have a certified case on. The CDC reports the number of deaths to date. These are cases. The reason I share these two dissimilar studies, a CFR and an IFR, is they both indicate that COVID-19 is a disease that predominantly devastates the older and ill of our population. This does not mean that children and the young are not sickened and harmed by COVID-19, simply that it is not a significant threat. For I want you to remember, every year, around 900 children under 12 die in motor vehicle accidents. Around 400 die in swimming accidents. Well, I am sure you've all heard the report of reinfection with SARS-CoV-2 virus in the US. I thought we were immune. What did I get wrong? And what is immunity? We have evolved mechanisms and structures to protect us from harm. One of these structures that protects us against tiny, unseen living agents outside our bodies, such as protozoa, bacteria, and fungus. And also it protects us against a coherent collection of molecules we call viruses that use our cells to reproduce themselves, and in the process cause us harm and illness. We label these agents as pathogens. The system and structures we have evolved to protect us against pathogens, we have labeled our immune system. And beyond protection against the external pathogens, our immune systems have evolved to protect us against internal pathogens, cancers. Parts of ourselves that have lost their way in their intended functions and now harm us. And this rich, complex, layered system, our immune system, can also lose its way too and harm us by confusing the healthy parts of us, the normal, with the foreign and harmful, and attacking those normal parts of ourselves. We call this autoimmune disease. Our immune system is layered, a defense in depth. For understanding, we have come to describe the immune system as having two parts, innate and adaptive. Innate immunity in the innate immune system is intrinsic, and it's almost indifferent to the pathogen. Its elements are barriers such as our skin and mucous membranes, chemicals, the acid in our stomach, and the environment within our bodies, our temperature, our fever, the pH of our blood, and the commensal bacteria that live in our gut. Along with these, the innate system also has non-specific immune cells, neutrophils, macrophages, natural-born killer cells, almost sounds like a rock group, and dendritic cells. What's more important, we have adaptive immunity. Adaptive immunity takes over if our innate immunity is breached. Through a team of specialized cells, the pathogen is examined for a unique marker, an antigen, and that is then processed to create a pathogen-unique response by our immune system and to summon and amplify the immune response in our body. And importantly, after removing and controlling the pathogen, the adaptive system creates a memory of the immune system pathogen. Yet so many questions remain. What does it mean to say, I'm immune? What does it mean if I was infected, but no longer have symptoms? Does it mean that I have no trace of the pathogen in my body? And if having cleared the pathogen or contained the pathogen, will I acquire the pathogen again, even briefly? And if I do acquire it, will I have signs and symptoms with the reacquired pathogen like the first time I got it? Will or will I not transmit this reacquired pathogen even though I'm immune? Here to add clarity to my naive and clumsy description of immunology and immunity, I am fortunate to have as my guest Dr. E. John Wherry, the chairman, Department of Systems Pharmacology, Translational Therapeutics, the Richard and Barbara Schifrin President, Distinguished Professor, and the Director, Institute of Immunology at the University of Pennsylvania. Professor, welcome to The Doctor Is In. What did I get wrong in my introduction? My ego lives elsewhere. Tell me.
Well, first of all, thanks for having me. It's my pleasure to be here. And honestly, not much. But boy, is there a lot more to dig into. So I think you laid it out, very, very clearly. But there are so many facets of how we think about immunity to this virus, how we think about the different manifestations of disease, how we think about the burden of death and symptoms in the elderly, and what do we do to protect ourselves going forward with either vaccines or natural immunity. So I think you laid it out very clearly, but it'd be great to take some individual topics and really dive into some details.
This immunity, is this a binary state like a light switch that's either on or off? Or are there degrees of it? Is it like a rheostat where I can tune up how much light there is in the room?
Yeah, it's much more like a rheostat. And it's like a rheostat if you can turn it up and down, but you also have multiple colors. So the immune system is extraordinarily complex. And often other scientists really roll their eyes at immunologists because we describe these hundreds of cell types and we give them all, weird names. And it can become overwhelming and confusing. But that's because the immune system has to deal with an overwhelming number of different challenges that we confront in our daily lives. We encounter bacteria and germs and pathogens all the time. We encounter allergens and other potential dangers from the environment all the time. And as you pointed out, we have to allow the immune system to react to those foreign things, but not to ourselves. And so one of the classic examples of thinking about the problem for the immune system is we can educate the immune system to recognize things it's never seen before. And those would be all the things outside of our body. But then you go through puberty, and all of a sudden your body looks completely different to that same immune system, or many parts of your body do. So the immune system has these major challenges and has developed a rheostat approach, can tune it up, tune it down, but also many different colors or flavors of the type of response. So the answer is, we are not binary in whether or not we're immune to a virus. The goal of a really good vaccine is to make it seem binary because we're above some threshold so the population is protected. But really, there are various mechanisms the immune system uses, some of which, as you pointed out, are innate and only last a short period of time, and most of the time can't essentially be trained for the long-term control. And then we have this adaptive immunity that we hope to train, teach, and have on board essentially for the rest of our lives. And so we have gray zones where we may be protected from disease, but not protected from infection. And this is an area that's worth talking about for SARS-CoV-2, where maybe upon second infection, we don't get sick again, but yet we have virus replicating in our nose or our upper respiratory tract, and we can transmit that virus. Maybe for the same amount of time as the first infection, but maybe for a shorter period of time. So the degree of protection may vary a little bit. And that's really important as we think about public health measures, what it means to actually have some immunity, but not complete immunity, and how we evaluate our vaccines that are racing towards FDA approval.
So there's a lot of similarities to things that we already have experienced. Do we just get one cold a season, or do we get multiple colds a season? Uh, this isn't new, that we can kind of reacquire and get temporarily colonized in some spots in our body. As a matter of fact, some of us actually walk around already colonized with pathogens that we do not get affected with. Bless us and keep us. When somebody becomes a Staph aureus carrier in the OR, we are going into the dark regions. And this happens. What's the percentage of people that carry Staph aureus? Probably about 10%. And we just have to work with that. Is there such a thing as community? Is there a thing called herd immunity? And is there something called cocooning? Could you tell me about that?
Yeah, well, there certainly is herd immunity. And in fact, herd immunity is what normally protects us all from measles. Now, for medical reasons, there are some people that can't get vaccinated because they have inborn genetic deficiencies in their immune system, or pediatric cancer patients who have their immune system destroyed because of chemotherapy can't get the measles vaccine. But they're protected most of the time because a high enough percentage of the population is immune. And so if one person contracts measles, they can't transmit it to anybody else very efficiently. And so the likelihood of those people who can't be vaccinated being exposed is low. So most experts talk about the level of immunity you need in a population to acquire herd immunity being somewhere between 60 to 80%, depending on the pathogen. So we clearly take advantage of herd immunity for measles. When our intentional vaccination rates drop, we see measles reemerge. And this is because we've dropped below that herd immunity threshold in local communities. Sorry, go ahead.
Isn't it true that for measles, we need a much higher herd immunity, north of 90%?
Yes.
That's R0 is huge, like 18.
Correct. So measles is one of the most infectious pathogens we've ever seen in humans. Measles and smallpox is probably one of the next ones. So the bar is much higher. Now the R0, the rate of new infections for each person infected for SARS-CoV-2 is actually very high. And this is, remember, it's a log scale. So going from 1 to 2 on this R0 scale is a massive increase, which of course means that measles is extremely infectious. When we talk about a really worrisome influenza strain, we're talking about an R0 of maybe 1.5 to 1.8. Early on for SARS-CoV-2, it was estimated that we may have been higher than 2, close to 2.5. Now that can change for a variety of reasons, but the point is that our level of herd immunity that we may need for SARS-CoV-2 is probably less than it is for measles, but it's still probably, people are estimating, in the range of 60 to 80% of the population needs to be immune.
Professor, you go ahead.
I was just going to comment, the cocooning idea of sort of isolating yourself and protecting yourself by no exposure, of course works, and we're going to see less infectious disease because of that. But at some point, you have to come out of the cocoon, and if there is no immunity outside of that, you'll still be in trouble.
You referenced, Professor, vaccine development. Now, in my naive world, we haven't had a lot of successes with vaccine development. We have had huge, massive triumphs, change the world kind of triumphs. But we also still struggle. We do not have an AIDS vaccine. And every year we have a seasonal influenza vaccine that varies in effectiveness from like 19% in a bad year to like 60% in a good year. Mm-hmm. What do you think we're going to see with SARS-CoV-2?
Well, I think we're going to be on the better side of the equation, but it's still a big unknown. So you raised the two most difficult, or two of the most difficult vaccines to make. HIV has thwarted our attempts to make a vaccine for 35 years now or more. And there are a variety of interesting scientific reasons for that, and that could be a whole show on its own. Similarly, influenza is a monumental problem for some very interesting virological reasons. The virus is actually not one virus. It's a whole bunch of different kinds of virus that actually trade genetic material all the time, sort of like a big Lego set, and you can rebuild it in multiple ways so it looks different each year. And then on top of that, the Legos actually mutate within themselves. So influenza is a very difficult problem.
So is that when they talk about a genetic drift and a genetic shift, is that what they're talking about?
Exactly. So the genetic drift will be the incremental changes in the virus genome over time. The genetic shift is, virus over here swaps 10% of its genome with a virus, say, from pigs or from birds. And now it comes into humans, and our immune system has never seen that new piece.
So that means that a virus that has just us as a host, we could probably reasonably make a vaccine for. But if it's got multiple hosts, we have a huge problem to account for that shift, not the drift of the antigen. I can see why there's problems here.
Yeah, and that's maybe an unusual case for flu that has what's called a segmented genome. So it actually has these sort of Lego building blocks. Mm-hmm. For coronaviruses, it's a single linear genome, or circular genome actually. So it's more difficult to swap pieces very easily. Now, I'll counter the HIV and the flu examples with two other examples where we actually have had great success. One is the rotavirus vaccine, where in fact we had one of the biggest vaccine trials ever, and we have an incredibly successful vaccine against rotavirus now that has saved a lot of kids' lives. And the HPV vaccine, human papillomavirus vaccine, which in fact is preventing cervical cancer by vaccinating actually young men and women for HPV. So we've had some great successes over the last couple of decades. But as you point out, these are massive efforts. They often take a decade or more to get these vaccines to market. So how do we feel about our prospects with a SARS-CoV-2 vaccine? We have made vaccines for the original SARS virus that emerged about 15 years ago, and for Middle Eastern respiratory virus, MERS, two close relatives of SARS-CoV-2. They were incredibly effective in preclinical models. They were tested in humans and showed very good generation of immunity, but they were never needed because those two viruses actually didn't end up transmitting from human to human that effectively over time, and they sort of burned themselves out. So if we look at sort of the background template, we have good reason to think that this virus may fit the same mold, not behave like influenza virus, not behave like HIV. But there are many unknowns. I will also point out that despite the urgency and the real need from all of us to have a vaccine faster than we have it, this is the fastest we've ever done something like this. From the time the sequence of this virus was made public to the time we started making the first vaccine was 3 days. From the time the sequence was made public to the first injection of a human being tested for this vaccine was 66 days. That's 100 times faster, maybe more, than anything we've ever done in history. So we are moving forward very quickly. Because of that, we have to make sure that we're being safe, that we're really assessing things carefully, and making sure that whatever it is that gets approved and brought to market actually does everything we think it does and is not harmful.
What do you see, Professor, what do you see as a timeline to having people lined up for the shot?
Yeah, I think there are really three components to that. And the first, we are way into the race, and that is doing the trials. We have 3 vaccines in phase 3 clinical trials with tens of thousands of people and controls being enrolled in these trials. We will get a readout of one or maybe all 3 of those trials sometime this fall. With the readout of those, with both efficacy and safety from those very large trials, we will see an FDA approval. Traditionally, if everything works the way it's supposed to, I would say by late in the fall. And of course, the landscape of that is to be determined. Once one of these is approved, we have 2 other hurdles. One is to make enough of it. And of course, we've spent an enormous amount of money building manufacturing already, what we call at-risk manufacturing, to make these vaccines before we know whether they work or not. And we could argue about whether that's a good bet or bad bet, but we've spent $1 billion, maybe $2 billion making this stuff before we know if it works. We still have to finish making it. We still have to make sure that quality control is good. So that's the second hurdle, is production. To me, the bigger challenge is implementation. How do you line up 200 million people and vaccinate them? We have already seen the massive challenges to our healthcare system with the number of infections that we've seen. So where do we vaccinate these people? How do we ensure that if we vaccinate at commercial vendors, your local drugstore or, Walmart or Target, how do we make sure that we're doing so in the most efficacious way possible, and that we document who's been vaccinated, and we make sure we aren't, using the vaccine, that we are using the vaccine in the most judicious way possible. So I think the implementation is an area where we need to have some clarity on how to do that. And rolling out federal programs for implementation of something at this scale, I think we should be asking questions about how that's going to happen right now.
Would it be reasonable to prioritize who gets the vaccine?
For sure.
I am not sure that our college-age students without any coexisting significant condition have a need for it. But certainly our older population and those in proximate contact with the older population, they got to move to the head of the line.
100% agree. And I think there are two ways to think about that problem of how you prioritize. There's the high risk, and then there's the high transmission. And I think the high risk we know, and as you pointed out in the opening of the program, I think we can vaccinate those who are at the highest risk for severe complications and death. We can vaccinate, especially for assisted living facilities, those who work there, those who service those facilities. And there are a few other places, certain hospital workers, that should certainly go to the front of the line. Then there's the high transmission. And this is an area where we actually don't know as much as we probably should at this point in the pandemic. We have a lot of anecdotal sort of popular press reports of where we see pockets of transmission. So, close the bars. Close the bars. We know that we're getting high transmission in environments like that, but other than that, we don't really know. So we don't understand the rates of transmission at universities and primary schools. We haven't done a great job nationally at contact tracing and surveillance. So I think prioritizing based on need for the individual must be first. Then prioritizing based on transmission so we can end the pandemic and get back to work has to be a consideration for how we roll out the vaccines.
I found it interesting when we talk about transmission, we talk about super spreaders. And a while ago, there was an article that was reported showing that children are super spreaders. Mm-hmm. And the term super spreaders, I thought was very unfortunate. All the article showed, and I'm trying to remember where it was published, but the article was one of these observational kind of articles where somebody did quantitative studies of antibodies, neutralizing antibodies, and determined that yes, children do get the virus. Yes, children, when they're sick, they have a lot of the virus, but they made no conclusion that that was the source of the spread. And I say that because there's lots of observational epidemiologic studies that exist forever that the American Academy of Pediatrics relied on in making the recommendations about children physically going back to school. I think you alluded to earlier about a risk-benefit trade-off. What do you see the way forward to get us to a safer spot so that we can have life again, or at least life as we've come to expect it?
Yeah, I think it's a really important question that all of us should be asking. I think there are probably three things. First and foremost, we need a vaccine. Even when we have a vaccine, it may take a year to get vaccine implementation to a point that we actually have herd immunity. It may take longer. So we're going to have this through 2021 in some form. I think the second thing that we can understand is where we're having transmission. So better information about contact tracing, better information on exactly what you said. Do kids actually spread? And if they spread, are they spreading at school to teachers? Are they spreading to other kids, to grandparents? And then the third thing is our own personal responsibility in this. We can control that rate of new infection for every infected person by wearing masks, by thinking about our behavior, by recognizing those environments that are a higher risk, and perhaps not taking the grandparents to have dinner out with the kids at a restaurant that's crowded, to think about ways that we can interact that reduce transmission in our local community. And I think combining those three things will get us back on track much more quickly than any one of them by themselves.
I'd like you to comment. I found it fascinating to see, number one, what Sweden's done, and number two on that, how little objective reporting there is about Sweden. It's almost all with exaltatory or condemnation of what Sweden's done. If you look at their numbers, they have fewer deaths per million than we do in the United States. Mm-hmm. And they have basically, they've sort of discouraged a lot of bar contact time. Yeah. But if you look at the Swedes, they're walking around without masks. Now, you can't compare apples to cinder blocks, but you can compare one apple to another apple. And it's the human species that I'm looking at in Sweden. And I'm just amazed that they are doing better in deaths per million than we are. Where am I wrong on this?
No, I think you're right, but I think there are a couple of other things to keep in mind. So just briefly. So one, they did close bars or limit bars, and we know that that's turning out to be one of the biggest areas of transmission. We did exactly the opposite. The overall approach in Sweden does not look like it's going to reach herd immunity as quickly as they wanted. So they've actually modified. It was a good experiment, but it's going to take longer to reach herd immunity than they thought. And then the third thing, and this is a whole nother topic, is the comorbidities in the Swedish population are quite different.
Yes.
Have the degree of cardiovascular disease, obesity, diabetes, and other things that are driving a lot of our morbidity and mortality in the US.
I completely am aware of what you're saying. And some of those comorbidities we get to decide ourselves, don't we?
We do.
Body mass index is not something that we get from our water supply. It is something else entirely. Enough said there. We could go on there forever. Professor, I cannot thank you enough for this. This has just been a wonderful exploration. I love what you said earlier too about there's so much more about this that we need to discuss and we need to research on and speculate on. So thank you for what you're doing right now. And what an incredible career you've had down there at Penn. I'm always embarrassed when I have a guest where it takes me half my intro just to read their titles and their positions. Congratulations, you're making a difference. And for those folks who are watching right now, thank you for watching The Doctor Is In, and stay safe.